Hi, now I will be talking about a case presentation. It's an 18-year-old child from Pune with the 2 episodes of hematuria. On ultrasound, we have 14 to 10 polypoidal lesion in the bladder. They did a TURBT for that, and in our hospital we got a review, and MRI was also reviewed. As a follow-up, as a protocol, they also did urine cytology. Urine cytology was given as high grade for high-grade urothelial carcinoma. So, as per NCCN guidelines, whenever there is suspicious of bladder cancer, you get a history, germline testing for Lynch related cancers if the patient has younger age, cystoscopy, abdominal pelvis imaging, and if there is history of smoking, screen and actively counsel them for quitting smoking. So then you have underneath TURBT, and then depending on what is the biopsy report, we will further go ahead. So in this case, before we jump into the biopsy TURBT review we got, let me explain about normal urothelial architecture. It is composed of 3 layers. Basal cell layer is small, cuboidal and have condensed chromatin, and then we have layers of intermediate cells which have which are perpendicular nucleus, and then we have superficial umbrella cells. These umbrella cells occasionally might have a nucleus and might have prominent nucleoli. The thickness of this complete whole thing would be 4 to 7 cell layers. Also, coming to other layers of urinary bladder, we have lamina propria and muscularis mucosae. Mucosae is a small wisp or smooth muscle bundle, and if you see huge bundles of muscle, that is muscularis propria. So in the muscularis propria layer, we might also get fat. This fat should not be considered as confused with perivesicular fat. It is important for urinary bladder staging. It will upstage the tumors if the tumor is spreading into perivesicular fat. Also, what is this? These are worm-burn nests. Worm-burn nest, they are solid. If they change into if they generate worm-burn nest or smooth contour, sharp borders with lamina propria. The cells are bland with no mitosis and no atypia. The same cells go proliferative changes with cystic changes called cystatic cystica, and if undergoes intestinal metaplasia, we call them cystatic glandularis. Okay, so now what is the difference when do you call a lesion a flat, when do you call a lesion a papillary? Flat lesions grow along the surface without any projection. There is no fibrovascular septa, whereas in papillary lesion it's exophytic growth growing towards the lumen with a middle fibrovascular core. Okay, so now we come into the case. This is the lowest power 1x. So we see some polypoidal fragments lined by urothelium. Urothelium appears to be thickened in some sections and 4 to 7 layers in some of the sections. Lamina muscularis propria could be there. Muscularis mucosae could be there, but no muscle bundles, huge muscle bundles are seen. That is, muscularis propria is not included in this biopsy. Okay, coming to this higher magnification, we see the cell layers are increased in some of the sections, some of the areas, more than 7 layers thickness, and lamina propria inflammation is seen. In this magnification only we can see some big cells, right? See, there is some big bizarre cells in between popping up. as I talked about earlier, the layer is variable throughout, but what notice that the umbrella layer is intact in every single one of them, right? Okay, so coming to the we had done with the architecture and the layering. Now we come to the individual cells. So there are pleomorphic cells in between, but mostly the biopsy shows somewhat uniform cells. They are not there are some abruptly pleomorphic cells, we would call. Okay, these abrupt cells are limited up to intermediate cell layer. Umbrella cells are maintained everywhere. There is some apoptosis happening. One notice that the polarity of the intermediate cells is mostly maintained. They are perpendicular to the basement membrane. Here there is inverted growth pattern. The cells are seen in the lamina propria with inflammation surrounding them. Not great inflammation, but there are some vessels and some lymphocytes. Again, inflammation, bizarre large cells. This nucleoli has irregular nuclear membrane. Nuclear enlargement is seen, blebbing is seen in the membrane. The chromatin is hyperchromatic. Nucleoli is not that prominent. In this, there are some prominent nucleoli. Also, there were some mitosis as well. 1, 2, 3, 4. 5. So they're all limited up to the basal and few of the intermediate cells, but superficial intermediate cells are mitosis were not there in those sections. There was some macro big nucleus that I wanted. Also, there is one mitosis there. So after seeing the microscopy, we had to decide what we think about it. It's a papillary lesion. It's a non-neoplastic lesion. If it's a non-neoplastic lesion, we want to decide whether it's hyperplastic or reactive. If it's a neoplastic entity, we have to decide whether that's a dysplasia or carcinoma in situ or a frank carcinoma. So to understand these lesions of the urothelium, we have spectrum of lesions. We have previously it was simple hyperplasia, atypical hyperplasia, carcinoma in situ, and now 2016 WHO 2021 jobs normal, AUP flat, dysplasia and CIS. Yeah, okay, so coming to each one of them. Okay, we have to ignore the diagrams. We'll just read out the histology of them. Urothelial hyperplasia could be flat or papillary. Papillary if we have a fibrovascular core, and if it's not, it's a flat urothelial hyperplasia. The thing is, there is increased cell layers and orderly maturation and minimal cellular atypia, right? And in a papillary hyperplasia, again there is mildly thickened, but the cells are planned. There is no atypia and there is orderly maturation. Once you have a context of inflammation, the changes would be there. So these changes, if they are secondary to reaction or to inflammation, then we called it a reactive urothelial hyperplasia, atypia, sorry. And then we have dysplasia and carcinoma in situ. Previously it was called known as low-grade intraepithelial neoplasm and high-grade intraurothelial neoplasm. So now anything looking like high-grade intraepithelial neoplasm by definition is carcinoma in situ, and low N is by definition dysplasia. Dysplasia is a single term. We don't have high or low dysplasia in urothelium and bladder. So what is the difference? In low-grade N, or now called as dysplasia, there is disordered architecture with cytological atypia. Architecture is disturbed, cytology is disturbed involving lower to middle cell layers, but the superficial or upper layers will show some maturation. Whereas in high grade IN, that is now called as carcinoma in situ, there is full thickness involvement, loss of maturation, and there is loss of polarity, marked nuclear ATPia is there. So the confusion between reactive atypia versus dysplasia, if we seeing the atypia, that is disproportionate to the amount of reaction and inflammation that we see, we can label that as atypia of unknown significance, right? So flats, hyperplasia and papillary are benign. As you go on, the increased architectural disorder and cytological atypia increases. It's the same thing explaining in this graph. Coming to each one of them again, in the hyperplasia part, there is no cytological atypia, or it's an isolated flat hyperplasia, has no premalignant potential. But if the patient is on follow-up and was previously a known diagnosed case of carcinoma, the hyperplasia in this adjacent areas will share or might share chromosome 9 deletion and FGFR3 deletion with mutations which are normally seen in carcinomas, urothelial carcinomas. This is called a shouldering effect. Okay. So, what was the initial lesion, or was there an lesion? You should know the history before. It should know our history. I think it would help us. So this papillary hyperplasia may be a precursor to low-grade papillary neoplasm, and atypical. If the hyperplasia is atypia, it may progress to carcinoma in situ and high-grade papillary cancers as well. We have two pathways of urothelial carcinomas: papillary pathway and flat or CIS flat pathway. So we have flat atypia, then flat low-grade dysplasia, and then we have carcinoma in situ. Carcinoma in situ with acquired p53 mutations, and if it's a FGFR mutation, will go into high-grade papillary, or with other chromosomal changes like 5p change, 9p, 13, 17. It might go into solid carcinomas. Also, there is one more pathway, hyperplasia or papilloma, go into pendulum, low-grade papillary lesions, high-grade, low-grade dysplasia, and high-grade papillary or carcinoma in situ. So next is reactive atypia. There will be a history of cystitis, infection, stones, instrumentation, drugs, chemotherapy, radiation therapy, presence with hematuria and lower urinary tract symptoms. Infectious causes could be bacterial, tuberculosis, viral could be CMV, which will be have a hemorrhagic cystitis, be fungal, protozoal schistosomal, right? Post PCG or posters, you will have reactive atypias. So it's what are the features that are better? Like you feel like it's not so bad. It's okay. It's not a malignant condition. There will be maintained nuclear polarity. There's vertical nucleus. There is no haphazard arrangement, and the order of maturation is based towards superficial, that is maintained, and you have a context of inflammation in the lamina propria. Whereas the skin's case, like it could be some dysplasia kind of thing. It could be nuclear enlargement will be there, abundant cytoplasm will be there, the nucleus will be vesicular, and you will start getting some prominent nucleoli. It may even come through frequent mitosis, but the thing is the mitosis will be limited to lower layers. So if there is no pleomorphism, hyperchromasia, coarse chromatin, don't think before giving it as a dysplasia, right? So then coming to dysplasias, it's a early morphological manifestation between normal urothelium and carcinoma in situ. It's a in between. It's a progressive change. Some, as I explained before, dysplasia is a low grade urothelial neoplasm. CIS is high grade intraepithelial neoplasm. So, but we don't have we should not use this high grade dysplasia, low grade dysplasia, high grade flat intraurothelial neoplasms, right? Now the thickness could be normal, increased or decreased. Superficial cells will be maintained, and cytological atypia will be limited to intermediate or basal cells in dysplasia. As compared to CIS, full thickness atypia will be there. Clearing is lost. Clearing is cytoplasmic clearing. Could be lost or could be maintained. Coming to nucleus, there is loss of nuclear polarity, nuclear enlargement, nuclear hyperchromasia, membrane irregularity will be there. The mitosis are limited to basal areas. LP, lamina propria, could be normal or will show some inflammation and neovascularization. It should only be diagnosed when we are telling the changes cannot be attributed to the inflammation, and at the nuclear atypia is not so much high and it's not involving full thickness to label it as carcinoma in situ. So if the dysplasia is secondary to in a case of a patient who already has previous urothelial or is presently having a urothelial carcinoma, so we call this secondary dysplasia. Whereas if there is no history of such, it's a primary de novo urothelial dysplasia. The study shows that de novo dysplasia becoming CIS or urothelial carcinomas is just 15 to 20%, whereas 19%, whereas it's a secondary dysplasia, the percentage of them progressing into carcinoma will be 30 to 36%. So coming to high grade dysplasia, which should not be used, it's a carcinoma in situ. Cells will be large, hyperchromatic, present throughout the entire thickness of the epithelium. We can pick that up in lower or medium magnification. Mitosis will be there, atypical forms will be there, and apoptosis will be there, right? So there is one more term that is called as atypia of unknown significance, where there is inflammation of lamina propria, but the degree of nuclear atypia is not giving up to that. It's not matching the vibe, so we call that as atypia of unknown significance. But it should not be. We have to try hard not to use it. So why the distinction is important is because reactive atypias and AUS in the study, none of them have developed any CIS or carcinomas, whereas the dysplasia lesions have 14 to 19% will develop to a biopsy-proven carcinomas, progressions at least. Yeah. So, coming to looking into all of this, I want to we have to place them in a reactive AUS dysplasia or carcinoma in situ. Carcinoma in situ is ruled out. AUS dysplasia we can call with the mitosis and all was not that great. Polarity was almost maintained. To call it reactive, inflammation was not that great as well. But there was some pleomorphism which would fit into dysplasia, but not so much so. So we might have to call that AUS. But also we can use some IHCs to prove the findings. So IHCs we can do are this triad of IHCs called as P53, CD44, CK20. CK20 is a urothelial cell marker, umbrella cell marker. Normally it is limited to umbrella cells, and CD44 is a basal cell marker limited to basal cell membrane. TP53 will be wild type, right? In a flat urothelial hyperplasias, CK20 will be only in superficial cells, basal layer CD44 and P53 is white. Whereas once you start getting reactive atypia, CK20 will be maintained in superficial umbrella cell. CD44 will be full thickness. That is the basal cell hyperplasia is there essentially. It's reacting to something, right? And but 53 will be wild again. It's not neoplastic yet. It does not occur. It does not gain the TP53 mutation. In AUS, CK20 can be even seen in deeper layers, not only limited to the upper layers. CD44 is full thickness, increased in all layers, but again 53 is still wild. In the dysplasia case, CK20 can come in the lower layers as well. CD44 is absent, right? And TP53 will be wild type. TP53 will be wild type. The same thing. So coming to our case, we have CK20, which is mostly superficial umbrella layers with some of them in the intermediate cell layers, right? And CD44, which are basal cell membrane. In some of the areas it's just limited to basal layers, but in some of the areas it shows full thickness. It could be either reactive atypia or AUS, full thickness. So TP53, it's strange in this case. It was like some of the cells have overexpressed, and some of them had loss. So that was a difficulty in this case. What do you want to call this? There is some loss areas, there is some overexpressed areas. So this one area of interest we had was inverted growth pattern area. In that area, let us look at the IHC. CK20 is even present in the intermediate cell layers, or they are present for CK20, and CD44 is negative. CD44 is negative is, let us go back, it's a bad sign. It indicates it is becoming dysplastic, right? Even CK20 we saw that it's coming in full thickness of the epithelium, and TP53 in that area was over, like I don't know, it was overexpressed. Hydroplakin is a marker of umbrella cells. CK20 was done. It's a origin of urothelial cell. CK7 will be used. So in this case it was very confusing to call was it a reactive atypia, is this dysplasia? Definitely not carcinoma in situ, right? So it's a gray area. AUS could be given, it could be given as reactive atypia, so it's the choice. It's not a choice, you have to give a guarded diagnosis. You have to be careful since it's a 8-year-old kid. So yeah, what do you guys want to call this?